do it all the time because they don't have a special bed.
Yeah,
But probably, but they probably because they're much lighter too. Also, that make a difference.
I can never sleep on my belly. I can't lay on my this is my back. This is my back.
In Asia, they have no choice because they don't have a special bed.
Do they end up having to do some propping with pillows and stuff? So. Oh yeah. Right. Yeah. Seems like my used to be a rehab person. You only get the patients that would have an amputation. Yeah. They use yeah. Yeah. Oh, you had to go there for 30 minutes twice. Yeah, twice a week. Yeah, it was. I mean, I was a rehab nurse for over 20 years. Yeah.
So later, if they want to ask a question over there, they will relay to you. Yeah, they can relay then. No problem. Oh, they can send you an email right away. Boom, pop it up.
The weird thing is I've seen that same similar kind of thing. I'm not sure what the quality is, but I've seen it in catalogs and not medical ones necessarily. It's actually for pivoting. I don't want to for. Still a good thing. Some people would use it for just standing. Yeah. He likes to have that at its appointment so that he doesn't get That's such a good idea. Because we can't be up very long. The dynamics of it, but most of the time it doesn't take long.
Still working here.
Okay.
Yeah, a few more minutes. Okay, Katie, if you can hear me, give me a call. I'm waiting for your. I'm available. Make sure you're up and running.
So do you have somebody else over at Evergreen doing food? Yeah, well, so kind. Counterpart, Dan Hankin, is over there. So some good. I really
It's only get worse.
well, driving here to Evergreen at 5 o'clock is like a challenge.
You use 520 or you use
I used to actually, but I mean generally 522 over, through Bothell.
oh, all the way around? Oh, that's a long road. Oh, that's a long way.
Traffic and stuff. But I mean, Evergreen's not that far south of where it connects with.
Oh yeah, that's true. Yeah, that's true. Yeah, the moment you connect, yeah. But the traffic get bad everywhere nowadays in Seattle.
I usually cut through like Bonita and then go up Lemon Road. Yeah.
You lost the signal? Okay. Okay, but you're. Okay, great. Thanks. Thanks, you. Goodbye. Okay, then you got it. Sure.
Okay.
Okay, everyone, welcome to SWAC. We're live from Northwest Hospital in Seattle, and we have another group of people watching from Evergreen in Kirkland. So welcome to everyone. Hopefully we can do this online more often. We have, before we go on to Dr. Luu, talking, I just want to remind everyone at Evergreen and here at Northwest that this is broadcast live, and so anyone in the world can see it, so please don't discuss any patient names. Keep that part quiet. You know, we can still discuss patient situations. We just need to make sure that we're staying HIPAA compliant or protecting our patients' privacy. So without much ado, actually, let me explain what's going to happen. Dr. Luu's going to talk for an hour, and then we'll stop broadcasting live, and at Evergreen, I believe it's Dan, we'll have 10 minutes to talk about Mölnlycke products, and then Perry here at Northwest will talk about Mölnlycke products too. So without further ado, Dr. Luu.
Well, hi everybody. My name is Paul Luu, and I'm just a plastic surgeon here in Seattle, Washington. And it just happened I do a lot of wound, particularly at Northwest Hospital. So today what I'm going to do is I'm going to share with you my experience about how I approach deal with a patient with a chronic open wound, especially deal with pressure sore. How I go about to do the flap surgery, the post-op care, and the wound care, they are related to each other. And I also want to share you my personal experience. Those things, particularly personal experience that I learned along the way. Textbook won't tell you that. It might not work for everybody. So when you listen to me, it doesn't mean you can apply to your situation. You just get the idea and go home, and you have to modify to fit your environment. Okay. And before we start anything, I just warn you, I have a tendency to talk fast when I get excited, and I don't enunciate. Just slow me down, I don't mind. And feel free and ask me any question, okay? So, before we talk about flap surgery, there's a few things you need to understand, particularly the definition of a certain term. So we will go over that, okay? So what is flap? The key point for you need to know the flap, the unit of tissue that have its own blood supply. That's the key, okay? It could be muscle, could be bone, could be skin, but it has to have its own blood supply. That's versus graft, like a skin graft. It doesn't have any blood supply at all. So the graft has to rely on the recipient blood supply, right? But when you talk about the graft, the flap must have its own blood supply. That's the key, okay? And typically the flap, we talk about a local flap, that means nearby the wound that you try to close, or the distant flap, okay? Some of the flap distance could be local too. It depends how you go about to harvest. But typically when you talk about distant flap, we're usually thinking about free flap. What that means is it still has our blood supply, but I practically cut the blood supply, cut the vessel, and hook to the recipient side. So that's a free flap, okay? So you need to know that. So what I mean by flap. Okay, and then we talk about flap, then we talk about what type of flap. For example, if the flap based on the tissue that composes the flap, then it could be fascia. That means it's only a very tough layer of anatomy, have no fat, no muscle, then we call it fascia. If it has fascia and skin, subdermal, then we call it fascia cutaneous. Okay, muscle, then either we call muscle flap, or you could call them, it's the name of the muscle, that's all. Okay, it muscle together with the skin, then we call them muscle cutaneous or myocutaneous. Very simple. When you understand under the term, then when you hear the plastic surgeon talk about, or you read, you know exactly what it is. Osteocutaneous, that means what? Bone, skin. Usually skin we mean dermal and fat a little bit, okay? Or osteomyocutaneous. Osteo bone, myo muscle, cutaneous skin. So that's pretty straightforward, right? Okay. So if the flap contain more than one type of tissue, then sometimes you hear people say the composite flap. Composite flap is a general term, but more specific when we talk about like fascial, myocutaneous, something like that. Okay. Now, if the flap we can identify based on the blood supply, then it could be either random, that means you don't have no specific vessel, you just cut and just rely on whatever the vessel can fit the flap, that random. Or pedicle, that means you know exactly what the axis of the blood vessel supply the flap, and the pedicle flap can be an island flap. That means we practically dissect the vessel out. Okay, so that, for example, the DIP, that's they call it deep epigastric inferior, whatever. That's the one usually we do breast reconstruction. Okay, based on the vessel. Zero flap based on zero artery. Okay, so that island flap. And now I put down here for you another term they call the propeller flap. That it become very popular. The propeller flap is very similar to island flap. That means you practically dissect, could be skin, subcutaneous, whether cutaneous, based on the vessel supply to that island of skin, through the muscle all the way down to the main vessel. We practically take up everything except whatever the part we need. And propeller, that means it can move anywhere the way you want. Okay, so it's a lot of new terms, but the key point is you need to know based on the tissues, based on the blood supply. So when you read the op report or the doctor talk to you, know exactly what he does, and that makes sense. And when you know exactly where it's coming from, that will help you to know what you need to do with it after surgery, versus you have no idea where it's coming from, a free flap or not. Okay, so typically we will name anatomical like Gluteus Maximus. Okay, and then the flap type could be myocutaneous. Okay, and then the direction you move the flap, it could be rotational, or it could be advancement. For example, when I say Gluteus Maximus myocutaneous rotational flap, you know exactly where it's coming from, you know what to compose of, muscle and skin, and I rotate it. But see, advanced, you see? So that makes sense, right? So these are basic definition you need to know. Okay? Okay. As a surgeon, when you do the flap, I can tell you either you can see right there in the operating room whether it will be a successful surgery or fail, because you can see right there where it look pale or pink. Alright, simple as that. If it fail, it could be the total or partial. Okay, and when the flap failed, it could mean because it doesn't have enough blood supply, that one is ischemic. Okay, or venous congestion. If your flap is failed because the arterial supply, you know right away, right there in the operating room, the flap look pale, you know you don't have enough blood supply. But the venous problem, typically it could happen later on. Okay, so that means all of a sudden you see the flap look congested, look swelling, look more pink than normal. That when you think about congestion. And the venous congestion, usually that's the main problem for majority of the flap if you do well in OR and later on. Okay, particularly free flap. Okay, so you know the flap type, right? And when you know where the flap coming from, what it consists of, that will help you to, you know, come up with treatment plan, what you need to do after surgery. For example, if you know the flap had to deal with the lower extremity, then you know that after surgery you need to elevate the legs up, otherwise it's dangling down, grab its toe, it could cause venous congestion. It can kill the flap, right? Okay, so on the buttock, you know the patient laying in supine, you know that means they put weight on it, it can kill your blood supply, or friction, shearing, right? Or an oral cavity, you want to be moist. So when you know the flap type, the location, that can give you the idea what you need to do after surgery. Just very common sense, right? Nothing special, got it? But sometimes we don't think about it. So dial back a little bit, okay? Okay, so when you talk about flap surgery, particularly for local flap like me, I mostly have to do with pressure sore. So let me talk to you a bit about pressure sore, and that's the one you probably see the most nowadays, particularly with the aging population. We see so many pressure sore now, especially at the skilled nursing facility, because that's where most of the sick patients lay there for a long time. Either they paraplegic, you know, or they quad, or they just so malnourished and nourished they don't move, so they get pressure sore. So I can tell you, you go to a nursing home, you will find a lot of them have it, different staging. Okay, so when you do pressure sore, you need to know about the comorbidity, what contributes to the pressure sore. It could be because they had spinal cord injury, because it's too old, too weak to move, right? Or sometimes because the patient have incontinence, they get diarrhea, or they get moisture from your skin to macerate, right? So you need to know those things. Why you need to know? Because those will help you what to go about to take care of the pressure sore, and you have to eliminate this morbidity. Otherwise, it will come back again. Get it? So as a surgeon, yes, you can do the surgery, you can close the flap, if you toss the patient back to the same environment. I think for me that you defeat the whole purpose. So I need to know why the patient having that. If I can correct that, I will. If I cannot correct their spinal cord injury, then I cannot do anything. But I know, okay, it came from incontinence, then I will try to somehow divert the urine or divert the stool. Okay, so the most common location, weight bearing, bony prominent. Simple as that, right? Simple as that. And also, if you look at the bottom here, you see I say right here between young patient, that means they have more muscle mass and very less likely they will have sacral ulcer, right? Versus if you had a very elderly, sick and thin patient, and you know they predisposed more to sacral ulcer because they don't have enough muscle mass on their butt, right? This is something common sense. Sometimes we don't think about it, but you look at it, you hear that, that patient, I suspect she will have that, ulcer by look at how thick, how thin, how young the patient is. Okay, so there's a lot of things available to us, but sometimes we don't think about it, right? Okay, so pressure sore, what the contributing factor? We need to go over this very quickly. Number one, pressure. So you know that's number one cause of that. So your job will be try to eliminate it as much as possible. Okay, immobility, shear, friction, moisture, nutrition, steroid. We will go over this quickly. Okay, pressure. External pressure is the more important, because if you press against something hard, that external pressure right there, that is your number one enemy. So you will do anything to eliminate it. Okay, and the duration of the external is very important. Okay, especially nowadays we deal with the population a little increase in weight, so that make it worse. Yeah, there's a difference between 15 minutes of pressures on the 150 pound versus on a 300 pounder, right? That's simple as that, right? So we need to know about it. Okay, alright, so I put on this thing, just for your information, but you don't need to know. Just know external pressure, that's the key. Okay, so when you put the pressures on the patient, what tissue is the one who will get damaged the most or the fastest? Muscle is the guy. Get it? Muscle technically 4 hours to get ischemia and die. We normally tell the patient you need to turn the patient every 2 hours. It's not actually correct, but we keep it there. Okay, but 4 hours, that's when you begin to have possible irreversible ischemia or necrosis. Okay, the skin takes for a long time. You remember when you amputate the finger, if I put on eye, 12 hours later I can still put it back, right? So skin take the longest. That's why if you had the patient present with a little pressure sore, little black dot on the skin, but actually deep inside much more tissue dying at the inverted cone. Okay, so that is very straightforward, right? Immobility, that we don't need to go over that, because they don't move. That's why they've developed pressure sore. And the reason the people with spinal cord injury develop pressure sore, because they don't have sensation plus immobility. Okay, or very elderly, really sick patient, they cannot move even though they sensate, but they cannot move, so they have pressure sore. Simple as that. We see a lot of that on senior patient. Shearing, friction, these things sometimes we don't talk about that, but we need to pay attention to shearing and friction, particularly on spinal cord injury. Okay, these patients, they don't have sensation, so for you and me, if we have a little shearing or friction cause a little maceration, we'll feel the pain. They don't with spinal cord injury. That can progress to more ulcer. Okay, so turn the page down. Okay, moisture. That's another thing we need to pay attention. Too much moisture, you get rash, and rash can get to ulcer, right? And you practically can see the skin practically melt in front of you if they continue to have rash and everything, particularly if they have diarrhea, right? So we need to eliminate that by tell them. For example, I had a patient, have slightly decreased sensation in the buttock, right? Because multiple sclerosis. He's so hairy. He sweats a lot. So he macerate, and he has so much hair, so that it's a lot of bacteria. So to eliminate or to reduce it, we have to shave his hair. It's a little simple thing like that, but we can make it different. Okay, the moisture, particularly between the gluteal crease, you have to be careful, especially if the patient is obese. So the moisture will retain because we have more sweat gland there, right? So you need to think about little anatomy like that. Female, you need to think about vaginal discharge. Male, we don't care, but female you do. But for male, you need to thinking about moisture, scrotal sac. That's why you see a lot of spinal cord injury patient male, they have ulcer in their perineal region or the base of their scrotum. Okay, because why? Moisture. So you need to tell them you need to keep it dry by either blow dry, make sure you wear underwear that can absorb the moisture, evaporate quick versus retain the moisture, right? There's a lot of things you can help. Okay, of course, nutrition, simple, that I don't need to go over that. Okay, this to tell you about intrinsic, extrinsic. The extrinsic factor is the pressure, shear, friction, and moisture. Those are very important, and those are the things that you can reduce or eliminate. Okay, the intrinsic factor had to deal with a lot more with the nutrition, the vascular. Those things are a bit more difficult to deal with, right? Like nutritional status, those can take a long time to improve, right? So that take a little bit more, work to do. But extrinsic factor, you should be able to help the patient to get rid of it quickly. Okay, and number one problem, you remember pressure, right? So in the old day, how do we go about to reduce the pressure? This is what they do. You down pillow doesn't work anymore, and spatial bed, like make a hole or they make a donut. I went to Asia, I still see they don't have a technology like us here to have a clinitron bed or something. I saw some pressure sore patient in Vietnam. They lay on a aluminum gurney, aluminum bed in hospital, and they just had a form to cut out the hole for the sacral ulcer, and it worked. But the nice thing is that they're very light also. That help. If you're very heavy, 300 pounds, that will not work. Got it? So it depends. Okay. All right. So and then in the United States or more wealthy country, then we begin to have either low air loss or high air loss. The high air loss is the one the clinitron that you saw about. What it is, it's just fine sand bead, and we just blow air, and the air can evaporate through whatever it is. And nowadays we have low air loss bed. The low air loss bed are the bed I normally call alternating low air loss mattress. The key point, alternating. That means there are different air column. Okay, the alternator mean A, B, C, fully inflated, C, fully deflated, whatever. That's the key. And believe me, it works fine. Okay? But the high air loss bed probably the gold standard because that's the one studied the most. So we always use that to compare the other bed with. Okay? But it's so expensive, it's so heavy too. Okay? But again, reduce the external pressures. Very important. You need to eliminate as much as possible. Okay? So we just went over that, so we don't need to talk about low air loss or high air loss. Okay, so for me, when I see the patient with the pressure sore, how do I approach to deal with that? Okay, number one, good history. I'm talking about history, not exam. This is the key point for any medical field. I remember when I went to medical school, the first thing they teach us is 90% of diagnosis you will find in the history. So that still work with this guy. So the key point, every time when you consult, the first thing I ask, can I borrow the charts? I read. You scan, you read, you know what I'm saying? Believe me, that in the history we tell you a lot about the patient condition, their medical history, their social history, patient habit, and everything. So again, good history. And then from that, then I will think, why did the patient have the ulcer? I can get some idea from the good history, right? Okay, is that because of the wheelchair, or because the patient non-compliant, or the patient is reckless? I have patient, keep go out on the wheelchair and go get drunk, and he just fall asleep on his wheelchair. See? So you read history, it give you the idea. Then you will know why the patient had ulcer. Okay, and then from the history, I will know what the overall patient medical condition, right? That when I will try to formulate what can I do to maximize the patient medical condition, right? Again, there's a certain medical condition you cannot maximize overnight. To be aware of that. For example, if the patient is malnutrition, if they're, let's say, our women only 2.5, you won't be able to correct their nutritional status overnight. That takes months, because they continue to lose protein, through the wound, right? So that they malnutrition, that you need to improve. So I come up with a treatment plan. What can I do to improve? But I know that I cannot improve them overnight. So what that means is, it's unfair for the patient that I delay the surgery. If you read textbook, they will say you need to improve that. 3-month patient waiting. So what happened? You predispose them to get bone infection, all kind of thing, right? So you have to take those things into account, and and come up with a treatment plan. So don't read the textbook and do exactly what the textbook say. There's a lot of my colleagues using that to delay the surgery. I don't. Okay, got it? So from the history again, I will know about the social, financial, and psychological condition. These are very important. Why? Let me tell you. Social history. If you know the patient reckless, alcoholic, you don't correct that. He go out get drunk again, he sit in a wheelchair again, what could we do, right? Okay? Or, for example, the patient like to smoke. If you read textbook, they would say the patient should stop smoking at least 10 weeks, whatever it is. But you can't. Because for some patients, smoking probably is the last, the thing they have left them to give them joy, psychologically, whatever it is. You cannot really take it away from them. It's impossible to win them up or make them quit, right? So I learned how to accept that, knowing that it will increase the risk of my flap failure. I take that into account. You understand? So I take it into the equation, right? Financial. You better think about it. If the patient doesn't have any Medicare day left, they have to pay privately, go to skilled nursing facility. That's a lot of money. They cannot afford. Number one cause of bankruptcy in the United States is what? Medical cost. Think about it. Okay? So you think about it. So when I had a financial problem, I will ask my patient and I will figure out what can I do to help you. For example, the Medicare require you 3 days in acute care in order to qualify for SNF, right? So you should keep the patient in the hospital minimum 3 days, huh? Please. Versus just ship them out and then they have to pay privately, right? Or like they about to run out of Medicare day, so you begin to talk to the social worker, apply for Medicaid. So you can help the patient. It makes a huge difference. Okay? Or the patient doesn't have the money to buy supply, then you can ask for somebody to donate, something like that. It makes a big difference on the patient's psychological condition. This is very important too. You have to understand that, and this take a little skill or the little experience to recognize it. For example, the patient may have Munchausen syndrome. That means they prefer that ulcer to get attention. or they prevented an ulcer so they can get attention from their family. I saw that. Okay, so those patients, if you're treating them, I guarantee they will come back see you with another wound or the same wound. So you need to put a stop to that. Or sometimes the patient is okay, but the family member that's the one causing problem. You see, it's just you pay attention to how they interact with each other. You know, when you talk to the patient, you get the idea, and you guys, that's a problem with the family. Then I begin to separate the family with the patient out. For example, I don't allow the patient with the family by themselves. I make the nurse have to be in the room. Okay, so they don't reinforce each other, something like that. You have to pick those things out in order to have a successful rate when you deal with the patient. That may take a little skill, but when you pay attention to it, you will find it. Okay, and then when I, again, good history, they already gave me all of those ideas. I formulated, and then from that I will formulate my care. What can I do to prepare for the patient's surgery, and then what kind of flap can I do to close the ulcer, and I also formulate what can I do to take care of them after surgery. You have to have those things, otherwise it will fail. Got it? And in order for me to do that, I need a team approach. I need all of the help I get. Luckily now I work with the wound care center here. It's really make my life easy, because I don't need to worry a little detail from the beginning. My nurse already prepare all of the lab, or the physicians already for me. So they already have all of the lab, the workup for bone infection, I just need to review. That's it. You know, and then if I need some help to treat the bone infection, then I have infectious disease. Okay, and I have social worker help me with a financial problem, replacement. So team approach, that's the key. If the plastic surgeon like me, solo practitioner, try to do everything by myself, I'll be burned out very fast. Get it? Team approach, that's the key right there. Okay, so again, good history, still number one. And from there, I need to rule out infection, maximize medical condition. You know, make sure you get rid of all the moisture, particularly in female. If they have diarrhea, you know, then you need to either suprapubic catheter, Foley catheter, divert the stool, whatever it is, you know. Okay, and then educate the patient and the family. You need to tell them why do you have an ulcer. You need to tell the patient why you have an ulcer. So next time, what you need to do to prevent that. If the patient seems to be reckless or don't listen to you, they will have it again. Then the reason to do surgery. So I send them out until they learn the lesson. Then I will do the surgery, or I won't. Same thing I explain to the family, and I can guarantee you, if you really present that to the family member, when they realize why that happened, they will look at you like, wow, how come nobody told us before? Get it? They love to learn because they want to take care of their loved one, right? So make sure you take the family into your treatment plan and talk to the family, explain to the family why it happened to your son or your daughter, what can you do in the future, to help it. They love to do that. Okay, and then next step for me, I will plan now surgery. And this I think a little bit technical, for example, when I plan to do the flap surgery, I always try to avoid any scar from my donor side over the bony prominent, right? If I take tissue away from the bony prominent, that means I make it thinner, that means predispose the patient to have more pressure sore, number one. But for me, for this patient, particularly pressure sore, I always think, if the patient fail, what can I do the next time? What I mean is, I try to preserve any flap that I can use for the next time. Versus, you don't know, you go and you cut everything and you cut the blood supply, just tie your hand for next time. So if the patient, let's say the flap fail or they recurrent, I can maneuver some local flap again. Okay, so I have to plan that out in advance, because this patient, very likely will have ulcer again. It could be 6 months, it could be 10 years, you never know. So here, that's why I'm saying alternative flap for future use. Okay, right? And again, some of these I'm going to go very fast, okay, to technical, which I don't think you have to deal with it. The key point is you make sure you have a good debridement. When I debride this wound, all of the lining, the ulcer has to be gone. So what I do, I stain them with methylene blue. Anything stained blue, out, cut it out. So by the time when I debride, the wound very big, but I create a clean surface. Okay, I reduce any bony prominence, but I don't take out a lot. Because the reason, if you take out a lot of bony prominence, you change anatomy, so your patient be shipped to the other side, you predispose the other side to get ulcer. I just need to shade them up so they're not very sharp, that's all. Okay, and good hemostasis. If you get hematoma, potentially you can get wood adhesion. Okay. These are surgical principle, so I don't think you need to worry. That had to deal with a surgeon like me. Okay. Okay. After surgery, that a little difficult. Okay. So it doesn't matter how beautiful the flap you do, but you don't know how to take care after surgery. It doesn't do you any good. So I had to come up with that treatment plan before I go into. I prepare in advance. You know what I'm saying? So number one, again, minimize any pressures on the flap. Luckily, here we have some special like that. Okay, all of them require antibiotic for at least 7 days. Studies show that this guy usually require at least 2 weeks IV antibiotic. Of course, if they have bone infection, they will require even longer. Okay, we always push the drain to make sure you can monitor bleeding and also minimize the seroma formation. Okay, the JP drain. And how long we keep it there, it depends. If you read some journals, some article for 3 weeks, typically I keep it about 3 weeks. So it depends. So there's no fixed rule of that. I will look at the patient and depend on what the output and depend on the patient condition. I will make the decision based on my experience. There's no fixed rule that I follow. Usually minimum 2 weeks. Okay. The suture usually try to take out 2 or 3 weeks. But nowadays for me, I use absorbable suture because the reason why most of my patients after surgery, they will go to nursing home. I rarely see them. So I just use absorbable suture. I pick the one that fall up in 3 to 4 weeks. Then don't have to worry. In the past, I use staple, but then you have to take it out. You live long enough, they get inflammation, everything. So now I don't use staple anymore. I use absorbable suture. Okay, and for me, I don't use any absorbable suture that stay very long, like 6 months, like some suture we have. It can last a long time. No, I don't use that. Usually 1 month maximum. Okay, to minimize inflammatory reaction. Okay, and again, very important. You have to educate your patient and family member. You got to tell them. Okay, now you hear what you need to do to prevent that. And you educate the family so the family can get on the patient if the patient doesn't follow you. You know what I'm saying? So it's very important. They need to know these things. Otherwise, they come back to see you. Okay? And again, when the family and the patient understand why you order a certain thing, you make them do a certain thing to help them, they will appreciate it more. Versus you just tell them, no, you don't do that. You don't explain to them. They don't like it. They will rebel. Get it? You got to explain to them what the reason you're doing that. Okay? Okay. So again, any surgeon, when you do reconstructive surgery, we always try the simplest one to the most complicated. So for surgery, for pressure sore, the simplest one is direct closure. Nobody do that. It will fail. Guarantee 100%. You just cannot close the pressure sore completely. Trust me, it will fail. Tension, it will rip right through. The next one is skin graft. No, it doesn't work either because you already expose the bone. You can't, and you need something to build up, to cushion the patient. So majority people will do local flap. I never seen anybody doing a distant flap, free flap, because that technical, very difficult. You can do it, but nobody will do because the risk of failure is so high. Basically, this patient very likely likely they have recurrence. So nobody do free flap on pressure sore at all. Maybe the elbow, but not on the buttock. So mostly just rely on the local flap. Okay, so let me go a little bit quickly about this local flap, particularly when to do pressure sore. So most of pressure sore you deal with usually sacral, ischial, trochanteric, and elbow, right? The thing you probably see the most is sacral, ischial, and trochanteric. So we go over that quickly. For the sacrum, see, I list from the easiest one to the most difficult. Almost 100% people using local flap right here. And the flap used the most for this guy is the Gluteus Maximus muscle. Okay? And for one side of the butt, I can easily do 2 to 3 flap from one muscle like that. It depends on how the ulcer big or small. I will show you some picture about it. Okay? And if that failed, then you can do the transfer back flap. That means you only fascia cutaneous from the upper back and swing it down. Now, but this slide right here missing one thing. Nowadays, a lot of plastic surgeons begin to do what I call a propeller flap. What it means is, yes, that means they only take the skin and the subcutaneous tissue based on the blood supply to the Gluteus Maximus. They don't need to take the muscle anymore. So practically you skeletonize the vessel, because typically the vessel supplied the muscle, right? And you have some big perforator go up to supply the subcutaneous tissue and the skin. So now what happened? They just find the big one and they skeletonize, tease up the muscle all the way down to the root. So they only move the skin and the fascia cutaneous on the vessel only. It practically become an island flap. So they preserve the muscle. So those type of procedure I think be good for the patient who's ambulate. You don't sacrifice the muscle, so they don't have problem to walk upstairs in the future. Okay, so that I have an update because they begin to do a lot of now. But again, it's still based on the anatomy, the Gluteus Maximus. You get to know what the blood vessel and everything. Okay, so the rotational is just the way I move the flap around. That's all. Okay, nobody do distant flap, but I have to list that for you. Alright, got it. So for the sacral, based on the Gluteus Maximus blood supply. Ischium, still the Gluteus Maximus because nearby there. Okay, and you will read textbooks. A lot of them they say the hamstring muscle or the posterior thigh flap advancement. Some of the article or some of the textbooks say that. No, I don't agree, because this flap very easy to fail, especially if the patient has spastic disease. The contract, you know what I'm saying? It will rip right through, the flex the hip. So no, it's not. I never seen anybody has spasticity on the butt, only from the hip. So the hamstring, right? Not on the buttock. Yeah. So I don't think that's true. Okay. Again, the Gluteus Maximus is still the number one choice. The gracilis, the muscle in the thigh right here, sometimes we use it rarely. Okay. Gluteus Maximus still. And the greater trochanter, again, number one choice now, the TFL, tension fascia lata. And again, now with tension fascia lata, we begin to do propeller flap based on the blood supply to the TFL flap too. So it allows to move more, because if you skeletonize the vessel, you probably can rotate almost 360 degrees amazingly. Okay. Yeah. Okay. Feel free and ask me any question about this. Okay. This is a little technical, of course, so we don't need to spend too much time about that. Okay. So when you do this flap surgery to close this pressure sore, of course there's always complication. And to be honest, majority of complication I blame on the surgeon, not from the nursing staff. Probably because your technical skill is not good, or you don't really adhere to good surgical, protocol. Okay. For example, if you don't control good hemostasis, that will cause that. Okay. So the number one is planning errors. Okay, that I blame that on the surgeon, not the nurse, right? What I mean is sometimes the surgeon not experienced, he developed a flap too small, so his skin island won't be able to close the wound completely, so he really try to stretch it. That can cause blood supply to occlude, or tension will cause the skin to die. Planning error, that's probably number one right there. Okay, so technical, that's all. So that's the key right there. And then the post-op error, that very rarely will happen if the doctor know what his order and everything like that. But I blame the surgeon most of the time. Get it? And the post-op error, then we can talk more about that. The ischium, again, complication is what? Planning error again for me. If you don't know how big the flap you design, and after you harvest it, say, oh my goodness, my flap is too small. That's when you say, what did I do? And sometimes you can see some of my colleagues, like to close the skin on top, you can see it underneath there's still a cavity, and you look at yourself and say, what are you doing? I'm saying, and they put a JP drain, and hopefully that will fill up. I don't know about that. You know what I'm saying? Technical error. Greater trochanter, still the same thing. Okay. This a little technical about the classification of the flap based on the muscle. I don't think we need to go over this. This really help us to know what kind of flap you can harvest. As a plastic surgeon, I need to know this thing, because I need to know the muscle belong to what type of blood supply based on this classification. So it will allow me to know where can I harvest the entire flap based on the pedicle, or can I divide the muscle into two? It depends on the blood supply. So this, as a nursing staff, you don't need to know this. The surgeon, you better know. You better know the anatomy of the flap, so you can go about to harvest. Okay. Okay. So let me ask you. Let me put out this case for you, so you can read about it, and I will go over with you how I formulate to deal with this. Okay. So we had a 65 years old male. He had a history, aka he had AAA repair. He insulin dependent diabetes mellitus. He got big ulcer for over a year. Okay. See, the ulcer still have foul odor, purulent discharge. I mean, he had necrotic tissue. Leave alone. Family support. Quit 32. Albumin's low. He's a little bit obese. Would you do surgery in this patient? Think about it for me. Okay, the patient infected, right? So the first thing you know is you need to clean it out, and then after that, will you do just flap? Okay, he's only 65. Okay, he have low albumin. He live alone. Am I afraid to deal with it? No, I still deal with it. Number one, I know his albumin is 5, probably because nobody take care of him. I won't be able to improve nutritional status within a month or 2 months. It takes at least 4, 5, 6 months. So I know that. That means what mean? What mean? If I do surgery in him, I need to thank this gentleman during the post-op course. So albumin 5 doesn't mean his flap or his skin will fall apart. It just may delay his healing, but it doesn't stop me to do the surgery. Get it? It could 32, not a big deal. He lived obese, not a big deal. So he have no family support. Leave alone. So what you going to do? If you do surgery and you just toss him out again, he will fail. So that's why you begin to ask him, you have any to help you support, you have any group that you can join to provide you emotional support, what you live in condition. So when I know under this thing, then I will formalize what can I do to improve the condition. Then I will present to the social worker. I talk to them, what can we do to line up, and you talk to the patient, say, I can do your surgery, but after surgery you need to go to this house. They can support you. We can try to provide it to you, so that way we'll help you for your wound to heal, and also to give you the incentive that you follow my recommendation how to take care of your flap. You see what I'm saying? So those are social issue, right? You need to address it too. You just can't do surgery and send them out. The nursing home don't care. I think that unethical. You do surgery, you send him out, that's it. Just done. I don't think that, for me, I cannot do that. Some other surgeon may do, but not me. It's not my style. Okay? He diabetic, you cannot cure diabetes. So you just have to do accordingly. Just chase him with insulin. Correct his diet, whatever it is, right? You know he have AAA, and you have aka that means very likely his blood supply to the lower extremity is poor. But we never had any problem in terms of blood supply to the buttock muscle. So that's not an issue for me. I don't care. So this gentleman, I did surgery in him. I clean him out. 3 days later, a week later, look good. I flap him. But of course, before I go in to do surgery, I have a long talk with the patient, discuss all of the issues and everything with him. And he agreed to go with my program. Then he commit to that, and I will do the surgery. You can see the way I do. I look at the patient overall picture. I plan in advance, talk with the patient, get agreement with him. He had to follow my recommendation. Then I will do surgery. Even though he has a lot of heavy duty, medical problem that can, prevent from healing. But I'm not afraid. Okay. This is the patient right here. This patient end up staying in the hospital almost 5 months. The reason is his wife died while he depressed. He tried to commit suicide. He failed by inject himself with a big dose of insulin. She was comatose. They found him lay on his butt. That's why he got a big sacral ulcer right here. Okay, so and then during the time in the hospital, his apartment is gone. So he's homeless. See what I'm saying? But again, he's only 65. He ambulated. So after cleaning it out, they called me. I said, okay, what am I going to do about this? So I had to sit down, talk to the social worker, talk to the patient, come up with a treatment plan. I say I will not do a surgery unless he can be placed in a skilled nursing facility for the post-op care. He have no insurance. So what that means is, if I do the surgery, he had to stay in the hospital a long time. And I asked the hospital, will you guys allow him to stay in the hospital? Or will any nursing will take him? None of the nursing home will take him. But the hospital said, no, Dr. Luu, you guys do, we don't care. In the meantime, we apply for medical coupon for him. So at least you plan, right? And I talked to him. I had to get a psychiatrist, geriatric psych come by see him because he's depressed because his wife died and everything. So we get everything rolling on him. So when everything together, I bring him to surgery and I did the flap surgery in him. He walked out the door. He go to nursing home, and then after nursing home, we already plan out. Then he go to one of the adult family. He had medical coupon, so the hospital get reimbursed. But the key point, what I'm trying to say, that you plan in advance before you do any surgery. Okay. Okay. Not a case. You have a 66 years old female with spinal bifida. Okay. Had non-healing ulcer over a year. She lived by herself. Poor eating habit. She smoked. Okay. She had good bowel product control, but not urine. That means she incontinent. So that's easy to deal with. You put a catheter in. She's done. Okay. She smoked. Will I stop do surgery in her? No. That's the only thing make her happy. I cannot take that away from her, even though I know it's not good for my flap. But I know what I'm going to, what I'm dealing with. That's all. But luckily, these are local flaps, so it's not free flaps. I don't have to worry too much about vasospasm or something like that. Usually, it die on the table on me otherwise. So I say, okay, smoking, that's fine. I know it's not good. I told her that's not good, but we accept it. It increased your flap failure. She accept that, and I accept with her. Okay, so she said that she had a good bowel program by herself. I'm not sure I believe in that. So after I talked to her, and she agreed to have a colostomy. But her colostomy wasn't that easy because she's spinal bifida, so anatomy really changed. But she did. Okay, and I did surgery in her. Of course, I had to ask a social worker to contact the local people, whatever, the local government come by, check out her house to make sure everything okay. And her living environment, everything. Because I don't want to toss her back into a house that she's hoarding everywhere. It won't do any good, you know what I'm saying? So I did that. Yeah? And I did the flap surgery in her. I use only this area right here, not only the inferior half of the Gluteus Maximus. I tunnel it through. If this flap fail on me, I can harvest another half based on the superior or the upper part of the Gluteus Maximus. I swing it down. Now, her greater trochanter right here, somewhere right here. That's a little scary, but I have no choice. Her greater trochanter right here, right? So that's a little close to the ulcer. But if she dehisces right here, I'm not worried because underneath that muscle, you put wound vac to heal just fine. Okay? She have no problem. See, that's another patient. I do this. From here, I swing on the way out to here. Hit greater trochanter right here. If this thing fails, I can do another flap right here. I can swing it down. I look in advance. I say, I will do this flap, which is the easiest for me to close it ulcer. So I design my flap out, and I said, no, I want to use the half muscle. Then I think, okay, the other half, can I swing in the future in case my flap die? So I think in advance. I just don't go in, just cut blindly, you know what I'm saying? I really plan it out. Because if you know anatomy, your Gluteus Maximus have 2 blood supply. You can practically divide in half based on the blood supply that from the slide I showed to you. So I know my anatomy, you know what I'm saying? So I plan in advance. I just don't go in to do blindly. I had to plan, okay? See, for example, this picture, if you look at her, same thing, ischio ulcer. I did the first flap, it fell on me, right here. I bring the patient back 7 days later, I swing another flap right here. That's why the patient have 2 scars. See? 2 donor side right here. And actually this patient have multiple surgery before by somebody else. You can see some scar right here. This is actually skin graft. They swing the little fascia cutaneous not good enough, so they put the skin graft. It fell. And it fell on me too, until I did a second flap. And he healed. Okay? So you better think in advance, because this gentleman will have ulcer again. So don't waste anything. We don't waste anything. We plan. Okay? Alright. So the bottom line is, when you come to pressure sore, team approach. Team approach. Here I'm very glad to work with all of these nurses. They very dedicated them to the wound, so they make my life easy for me. So they do everything in the beginning, so I just need to sit down, read, examine the patient, and come up with a treatment plan. And I'm very lucky we had some nurse on the floor here. They're very good to deal with it. And then we had a social worker here. She's really good to helping me to find a placement too also. So it makes a huge difference, and usually you will do well if you had a team approach and working out well for you. So, alright. So now, since we talk about surgery, about how to do supportive care, let's go back to the basic. You need to know about wound healing. It's basic science, so you can apply to your post-op care. For your surgeon, need to know when you do surgery. You do surgery doesn't mean the wound will heal. You better know about wound healing too. How the flap take how long we heal. So let's go over that a little bit, okay? So if you use textbook, usually they say the wound healing usually divide to 3 phases, right? It depends what textbook, how old the textbook is. Typically, we divide to 3 phases right here: inflammatory, repair, and maturation. That's what you need to know. Okay. Sometimes people call it differently. Some people add hemorrhage at the beginning. Okay, but no, just know 3 phases. Okay. Here we go. These 3 phases. What's the duration of the phase? It depends on the patient condition. And these 3 phases, they are, overlap each other. Okay. So forget about bleeding phase for me. just know inflammatory phase, it can last up to 3 or 4 weeks. The maturation phase or remodeling phase right here, typically by 6 to 8 weeks should be okay, but typically we tell the patient 90 days for the scar to mature. And let me tell you, it depends on your ethnic too. White people, the scar can mature easily within 3 months. I deal with a lot of Asian patients, particularly when I do cosmetic. It can take a year easily. Oh yeah, because the genetic makeup difference. I'm not saying anything big, but my white patient, within 3 months the scar fade, it's gone. Asian patient, they stare at me a year, still firm. Some of them 4 or 5 months, but some of them take a long time because they definitely thicker. Okay, so there's no fixed rule. Okay, most of the articles you read here deal with white patients. Get it? So so think about apply differently. Black patient even take longer like Asian. Okay, but the key point for you, you need to know that these 3 phases they overlap, right? In under these 3 phases, one phase you need to pay attention is what? Is the inflammatory phase. You have to pay attention to that. That's the key phase. If you don't have inflammatory phase, you will not have wound healing. Why? Simple. That is the first phase that your body try to repair anything, right? By recruiting white blood cell count, your white blood cell to kill bacteria, and from there your white cell will release on the chemical to recruit all the cell, right? Without that phase, there's no wound healing. Get it? So that's the most important phase. Without inflammatory phase, you will have. That's why the patient who immunosuppressed, you wipe out the white blood cell, they don't have an inflammatory phase. That's why no doctor will do the surgery. Simple as that. Simple. Don't think fancy about all the chemical they release. Okay, I just look at the basic thing. That's the first phase your body try to repair. You have to have that. Okay, you can see here I list on the thing that required happen during the inflammatory phase. You can read about it. I'd be happy to give you this, but the key, you have to have the phase. Got it? Now next, this tell you during the inflammatory phase what happened. Okay, cell respond, all kind of thing. Now the next thing you get to know, your inflammatory phase must subside in order for the wound to heal. If you continue to have inflammatory reaction, your wound will not heal. Because think about it, very simple. The first thing that inflammatory phase is what? Your body try to recruit the white cell into the wound, right? What does the first thing you do? Your white cell, the mast cell try to eat bacteria, right? To clean it up, right? So if you continue to have that, it will destroy everything. It will release all the enzyme, it will chew up all the good tissue. Until that thing stop, right? Before all the tissue generate, right? So what I mean is, the inflammatory phase have to slow down, stop, in order for the next phase to establish. Okay, so if that patient have some autoimmune disease, you look at the wound keep look pink, red on, they're not going to heal. One the example, if the patient have Pyoderma Gangrenosum, you probably heard about, right? If you don't suppress the immune system to slow down inflammatory phase, they're not going to heal. It doesn't matter what you do, it doesn't matter what dressing you do, it doesn't matter what surgery you do, it will fail. Just simple, right? Just think global for me, don't think little detail. I need that phase, but that phase better stop. If it stops, something wrong. Okay? That's what you need, okay? So when the inflammatory phase begin to subside, that's when the repair phase is coming in, and then okay, all of these things, the next couple of slides I'm going to skip very fast, just tell you what happened in these phases. You can read about it. Okay, maturation phase. Okay, so when you know those 3 phases, you need to know what factor or what chemical can put an impact on these phases, slow down or stop this phase to happen, then you will not heal. Chemotherapy, You wipe out their inflammatory reaction, they're not going to heal. So if you take certain chemical or certain too much enzyme or certain vitamin, slow down their collagen synthesis, it's not going to heal. So you need to know a certain thing that can slow down the healing, like they don't have enough oxygen, they malnutrition, or they on steroid. You need to know those things. What can affect these phases healing, and that when you try to get them supplement or hyperbaric or whatever you need to do to counteract those factors, then they will heal. As simple as that. I don't need to know about little detail like if that phase produce platelet deriving factor, tissue plumbing. I don't care. I just know the basic thing. That's it. Okay. I just need the history. I know exactly what the drug they take, and what vitamin they take that can prevent them from healing. For example, they take steroid, and I need to know what to give to counteract the steroid problem between healing. Okay. Think global. Don't think little detail. The detail, let those guys who do research publish a paper. We read about it, and we apply. That's the key. Okay. For example, I listed here oxygen. They don't have enough oxygen because why? Because the blood vessel is narrow. So you need a vascular surgeon to open up the pipe, right? Or hyperbaric. Simple. Nothing fancy, right? If you know they're on certain drug, the steroid, then what you do? You need to give them something to counteract steroid. Simple as that. Okay? For example, the patient take vitamin A. They take too much, it slow down there too. That's a way to counteract vitamin A too. So that you should be able to get those things in history, right? See, get a good history, then you should be able to know exactly what needs to be done. Okay? Vitamin C, the same thing. They malnutrition, they don't have enough vitamin C. Vitamin A, same thing. Okay? Nutrition. Now, nutrition you cannot correct overnight. It takes time, right? So you can be aggressive with the patient. I tell my patient, your wound not going to heal, you got to improve. If you don't like to eat, you have two choices. I can put the feeding tube on you, or I do the pack tube. If you don't like anything in your nose, then you have to have the pack tube. Otherwise, I won't treat you because I will fail. So you have a choice. And then from there, if they had a pack tube, you just hang the feeding at night time, pump it in, you know what I'm saying? And you surprise within a month or 2 months, they just turn around. Okay? But again, as I say, nutrition doesn't really stop me to do the surgery. It can maybe postpone 1 or 2 weeks, but I cannot wait until they're completely normal. That can take months, right? But you can deal with that during the post-op care too. But you have to take that into the equation to come up with a treatment plan. Okay? Okay, this drug I just listed here for you, certain drug that can affect. Again, zinc, copper, get them multivitamin with mineral, that's all. Alright? But again, don't expect them to correct overnight, okay? You just blow them up. Okay? Diet. Okay. Mechanical stress, friction, shearing. You need to eliminate those. Okay? Or edema. You need to eliminate those things. Okay? There's a lot of things you can do. Of course, infection. You come in and you see the wound keep have inflammatory reaction. That means they may have some foreign body or some local infection. You need to culture. But some type of disease that you suspect infection, but you culture, nothing come back positive, like Pyoderma Gangrenosum. You culture, it never come back positive. Right? You suspect that could be infection, but no. Then you begin to think something else. If you culture then come back negative, then you should begin to think about the patient may have some autoimmune disease. Okay? Or certain thing like spider bite sometime. Okay? So it depends. Okay? And as a surgeon, then I have to think about my surgical technique. A certain suture, or the way I close the wound, or the way I play the suture, it can strangulate the vessel, and skin dye that predispose to infection. But those, I don't think you have to do with that. Have to do with surgeon. Okay. Okay. So the key point for you to know is 3 phases of healing. They are dynamic process. They overlap, and the most important is the inflammatory phase. Alright? Repair cannot begin until inflammatory phase subside. That's the key. You have to have that phase, otherwise nothing will work. So, for example, look at this wound for me. The wound look inflamed, right? Why? Because the patient had dead tissues in there. Right? So the inflammatory reaction will not subside because you still have dead tissue, right? I mean, your body still try to clean it up. So how do you help them? Get rid of that tissue, and then the inflammatory reaction will subside. See, simple. So this one will not heal because you still have that tissue. So you apply the basic information you learn. For example, this one, Pyoderma Gangrenosum. Okay, you can see the tissue look very inflamed. You can see how pink and red they are. See that? You culture them, come back negative, and you biopsy them. It depends on how good is your pathologist. Sometimes they don't know what Pyoderma Gangrenosum look like, or it's unfair for me to say that, but sometimes because we don't provide them enough history, so they cannot make a good correct diagnosis or inadequate sample. That's certain. But when you treat them everything under the sun that you know still not healing, then you suspect it could be Pyoderma Gangrenosum, or some patient they just have fulminant inflammatory reaction. So what you do is you can test them, you treat them by, you can post them with steroid. I had 2 patients come in, everything failed, but it doesn't look angry like this at all. It look pink and red. Everything failed. So we put them on steroid, a little bit low dose, to slow down and to suppress it, the inflammatory reaction a little bit. They just turn around. That means those patients, I label them like not really autoimmune, but they just have a little bit too much immune response. Okay, so to think about those things, think simple for me. Don't think so complicated. Try everything, doesn't work, and think about autoimmune disease.
So when you say pulse, you mean stuff like that?
No. You need to. When I pose them, that means I put them at low dose. At the beginning, you can blast them right away. High dose for about 2-3 days or weekly, and then you tip it down to like low maintenance dose, and you monitor how their wound look like. And of course, you need to know what the complication, what the side effect of steroid. You better tell the patient, so you monitor them also. Especially if they're diabetic, if they complain of hip pain, you better be careful. Steroid can cause hip necrosis, right? Bone necrosis. Okay, so you need to know those things. You post them, you keep them there until the wound get better. And believe me, some patient they feel huge different. I had a patient have breast reduction. Just one side of breast for some reason it looked red hot. She frustrated, said, "Dr. Luu, it's painful, it doesn't heal." After 5 months, finally her doctor sent it here. I look at her and said, "That look a little angry, culture, everything negative." So I said, you probably have a little bit too much inflammatory reaction. I put her on steroid. Within 2 days she said, "Oh my God, Dr. Luu, you feel much better." Her husband do dressing. "Yeah, Dr. Luu, every time I do dressing before she screamed at me, but now she let me do dressing, no problem." Within a month she healed. See, she said, "Oh yeah, Dr. Luu, you're right, the steroid definitely help." And again, she doesn't have Pyoderma Gangrenosum. She just has somehow tissue reaction a bit too much, one side of the breast. So, okay. But again, when you do that, but you have to be monitor the patient, it's a side effect of steroids, something like that. Okay. But again, I still use the basic information about 3-phase wound healing. See that? Simple as that. Nothing fancy, right? Just common sense. That's what I call it. Okay. Okay. So anyway, so my personal approach when it comes to wound is that you need to know the 3-phase of healing wound. That I applied it to the post-op care too. I know at the beginning when I did the flap, you look at the flap, it will look inflamed, it looks swelling, because of inflammatory phase. Within a week, all of a sudden you see the edema subside, look less red along the incision. I know that now they go to the repair phase. And then I know The remodeling phase can take up 3 months. That's why I make my patient strict bed rest for 6 weeks, something like that. Okay. So for my personal approach when it comes to wound care, I know the basic information about 3 phases of wound healing, and I approach the wound treatment like cooking. That's what I keep telling my nurse. Cooking. The wound too moist, you need to take the moisture away. It's the same thing. You cook if it's too moist, and you add a little bit more. You know, get the moisture away. You know what I'm saying? If it's too salty, you put the lemon. From, you know what I'm saying? It's too thin, you put a little flour. That's what I do. Too moisture, I put alginate to take, to wick out the moisture. Simple as that. It's too dry, I put hydrogel to keep it moist. It's simple. And give it a little vitamin, give it a little spicy by put a little collagen in there, like fiber core, something like that. For me, it's just the basic information, common sense that apply accordingly to the patient. Now, let me get back to a little bit about my post-op care with the pressure sore. Most of my patients, I make them strict bed rest for 6 weeks. There is no fixed rule. If you go to Harborville, they're only 4 weeks. Some doctors make them stay longer. It depends. It just happened to me that I found 6 weeks be fine for my patient. Why 6 weeks? Let me tell you why. Again, 3 phases of wound healing. After inflammatory phase, you need the repair phase, right? Your skin can heal very well, but at the bottom your wound will continue remodeling. Your tissue need to stuck down to the bone, and typically the bone doesn't have good blood supply, particularly if the cortical layer of the bone is still intact, unless you cut it down to the medullary, So it takes a longer time to stuck down the bone, or it takes a longer time for your muscle flap to stuck down to the fascia or the layer that cover your bursa. It's very shiny, slippery. So if you don't minimize the friction or shearing, it will not stick down. Then you have a seroma. I saw quite a few patients. They look very beautiful and flap outside heel, and they come to clinic. Dr. Luu, oh, I did a flap. I did really well, but then 9 months later, all of a sudden I had a little hole, and that wound failed to heal. And I look at them and say, I bet you had a seroma deep in the inside. And for sure we ordered a CT scan or MRI, you see the big cavity underneath it. And by the time when I debride them, humongous cavity underneath. That's why I make sure the patient stays still, minimize shearing, minimize friction on the flap, on the bony prominent where I did the surgery.
Is that also why you insist on keeping the JP drain in there for so long?
No, the main purpose of the JP drain number one is to monitor any sign of bleeding. Right after surgery, if you see the output like 100 cc per day that you were bleeding, yes, and it does. If you have any little blood clot in there, it will liquefy, and you can suck it out. But it's not an excuse. Use a JP drain. Try to fill up any cavity that you don't obliterate. Got it? No, it's not. Your flap better obliterate any dead space, otherwise you will fail. I think that had to do with surgical skill, the surgeon. Okay, so JP is not for that. Right? The moment you reform a seroma, it's the minute a capsule, you're not going to heal. A teeny one maybe, but the big one, sooner or later, makes its way out, and you have recurrent ulcer. It's much more difficult to deal with. Okay? That's the reason I want them to stay bed rest, and I wrote the order. I always write the order. Minimize friction, shearing. Nobody allowed to drag my patient up the head of the bed. They have to lift, up. Oh, I supervise. If I see them, they hear from me. I'm very strict about that, and I order very clearly, and they know exactly what I want. Okay, I just want you to lay flat. Basically, that colostomy, you don't have to worry about change a diaper or anything. That's one of the reasons I really push them to have colostomy, temporary or permanent. They don't have to worry about stooling. You still have a little bit mucus coming out of your anus, but not a big deal, very little. Female, then I have to worry about vaginal discharge. So I ask my nurse to take a look at the patient private part. If they see any moisture, then I need to do something about it right away, because the vaginal discharge can run along your gluteal crease and go to your flap too. So for female, then a little step extra. Okay. Any questions so far?
So the seroma is mainly from the sharing bed.
No. It could be, but the seroma, I will blame on the surgeon. That means he didn't obliterate any dead space. That means his flap may be too small for the cavity, and then shearing can cause that because you sheared up before the tissue mature enough. Yeah. Because you remember, patient when they drag themselves out of bed, imagine 200 pounds to sit on that flap and drag. When I see that, I close my eyes. I don't want to see that. I will get on my patient case, and I explain to my patients so they know about it, and they don't want to go through the surgery again, and so they be careful. But if you had a non-compliant patient, there's nothing you can do about it. Then the patient has to accept a new ulcer if they have recurrent. It's not my fault.
And the only way to get rid of the seroma is to go ahead and dig it out.
Yeah. If you say the word seroma, that means practically a well-formed seroma. It has its own capsule. It epithelialized, it's very shiny. A tiny one to do just fine, but a big one like that, in order to heal, you have to shell the entire capsule to create a big raw surface. Then you create a big cavity, and somehow you have to obliterate that dead space again. Either put another flap, or somehow you have to collapse it together. Sometimes difficult. Very, very difficult to deal with. Not that easy, simple you think. Yeah. Any questions so far? So the bottom line, let me tell you this, and I do so much pressure sore. I don't think it, for me, I'm not saying I'm a gift from God, anything like that. I think because with team approach, it makes my life really easy, because the nursing staff at wound care, so they do over 50% of the work I need to do at the beginning. I just need to sit down and read the patient chart, and I just put all information together, come with a treatment plan, and then just carry it out. And sometimes the patient very difficult, and I have to come with a plan how to deal with that, to confront the patient, confront the family, and sometimes the patient very difficult. Let me tell you, I have to notify the nurse on the floor in advance. I just let you know that you want to receive a patient of mine. This patient is not that easy to deal with. The patient is, require high dose of narcotic. Don't be surprised. And the patient already talk bad about me because I don't allow her or she or him to have a certain thing because I don't think good. So the patient will complain. So just ignore that for me. They say, okay, I will relay that message to Dr. Luu and let me deal with it. It's unfair for the nurse to deal with that. I tell the nurse, just reflect those things to me. I deal with the patient. Because those patients, before I do the surgery, I already have the verbal contract with them. So they can complain as much as they want, but I say, listen, we talked about it before. You don't follow, I will drop you. And they will quiet down. That's what I'm saying. I deal with difficult patients, but I deal with it not in a rude way like I order to do. I explain to them. I explain to the family, and I tell them, this is what I recommend for you to do, for your best chance to heal, for your benefit. If you think that's good for you, then I request you to follow. Then I will try my best to heal your wound. Otherwise, then I will not do your surgery. You're wasting your time. You're wasting my time. And believe me, they are so desperate by the time. Usually they will say yes. And of course, I have some of my patients reckless. They change their mind afterward. They fail. I won't touch them again. They learn their lesson. And sooner or later, trust me, they will come back begging me to do something about it. Okay? Any questions so far? So again, team approach. Team approach. If you had a protocol, you had a procedure already planned out, and let me tell you, this case you can take care of it easily, and the patient will do well. The hospital will love you because the hospital don't lose any money. Then they have some income from the insurance, and think we work out well, but you have to have a team approach, well planned in advance, you know what I'm saying? And as a physician, I utilize all of the available around me with all the support I have. So majority of my flap pressure sore patients stay in this hospital usually, I would say on the average 4 days. The longest one I have is 2.5 weeks because she ran out of Medicare day for skilled nursing facility. Besides that homeless patient, that's a different. I'm not a primary physician, so I don't have to see him every day. Why I say in the 4 days? Because the system I have it here, thanks to the Northwest Wound Care Center, they had a wound care nurse go to a certain number of nursing homes. So after I did surgery here, I know that most of them are Medicare. It requires 3-day acute care to qualify for skilled nursing facility under Medicare guideline, right? Medicare we pay. So I will know my flap either is alive or dead after 24 hours. So I need to see them only flap twice, something like that. So by post-op day number 2, I already tell the social worker, okay, prepare to send the patient now by day number 3, number 4. After 72 hours. I give them the list of nursing home that my wound care nurse go there. And we talk about what the patient do before surgery. I want you to go to these things so I can keep an eye on you indirectly. So as soon as one of the nursing home in that list accept the patient out the door. And the wound care nurse from Northwest will round the patient once a week and report to me if any problem. So in that way, I still indirectly follow with my patient. And those nursing homes, they for me, my patient, they know exactly what my order, because I write out the order very, very clearly, and the wound care nurse know exactly what my style. So things work out really well. So I can, I can finish this case. Not difficult for me, to really be honest. Yeah. Any question? Yeah. Team approach. Okay. All right. Yeah.
Thank you, Dr. Luu. All right, thank you, Dr. Luu. Very thorough. I really appreciate it. There's several ideas that came up during your lecture that I can help with my current patients, including the ones that are non-flaps, so that's wonderful. Just wanted to remind everyone, or let everyone know before we sign off, that next month we are going to have SWAC will be held at Evergreen, and we're going to be discussing hospice wounds. And the meeting will be a discussion-styled meeting, and we have a hospice expert coming from the area, and she's going to talk to us about their perspective for the first half of the meeting, and then we'll have a roundtable and discussion to see how we can improve the care for our patients in the area. So look forward for that evite to come out, and of course that one also will be on YouTube. So and that's everything. So we're going to sign off. So Evergreen, you guys can do your thing, and just a second.
You can email me. If anybody has any question, feel free to email me.
Okay. So email him, and then we'll also put his email address on the YouTube clips so everyone can get to it, including those who are not here today. All right. Thank you again.